Good day, everyone. My name is Shreya Tadas, and I'm from the School of Computer Science at University College Dublin. Today, I will be presenting our paper on using patient-generated data to support cardiac rehabilitation and transition to self-care. My co-authors on this paper are Dr. David Coyle, who's also from UCD, and Jane Dickson from Beacon Hospital. Cardiac event is a life-changing event, and people face emotional and physical challenges during their transition from hospitalization to self-management. Supervised rehabilitation programs, for example, cardiac rehabilitation program, plays a vital role in supporting this transition. However, lack of knowledge, transportation, and motivation limits the uptake of such programs. Increasingly, e-health systems providing patient-generated data are showing the potential to overcome these limitations. But evidence regarding its routine use and effectiveness is mixed, and the commonly reported barriers include insufficient time, data lacking context, misaligned objectives, lack of trust, technology being a burden, usability, and other reliability issues. So, to increase the success of such systems when deployed in real-world clinical contexts, following key unmet challenges need to be addressed. Such systems should make sense to both patients and clinicians, be actionable to both patients and clinicians, and be feasible within the organizational and social contexts. The overall aim of the study presented in this paper was to understand how tracking and sharing patient-generated data, both activity or objective data, and experience or subjective data, could support patients and clinicians during a cardiac rehabilitation program. So we provide a detailed description of how patients, physiotherapists, and other clinicians engaged with and used patient-generated data. We also explore patients' attitudes towards self-tracking and sharing their data with both clinicians and peers, and we provide evidence that the approach that we have described in this paper is feasible and aided the transition to self-care. So the study that we have reported was divided into two stages. The first stage involved co-design with the cardiac rehabilitation team to develop a data system. The data system involved gathering and sharing objective and subjective data through consumer devices and self-report questionnaires. The second stage involved an 18-week field study where the data system was deployed in ongoing hospital-based cardiac rehabilitation programs. So the field study ran across 4 separate iterations of the 6-week cardiac rehabilitation program that was provided in the cardiology unit of a large hospital, and it involved 16 patients. The second stage involved ethnographic observations and semi-structured interviews with patients who participated. So the stage 1, that is the co-design with the cardiac rehabilitation team, resulted in developing the final data system, which involved off-the-shelf wearable technology. Here, a Fitbit was used and a web application with functionality to answer weekly questionnaires. Alerts through SMS and email were sent to patients at the end of each week with a reminder to fill out the weekly questionnaire. The system was designed to fit within the organizational structure and schedule of the cardiac rehabilitation program. Findings from the ethnographic observations and semi-structured interviews that were conducted during stage 2 of the study suggested that the use of commercial activity tracker was well received by patients, and it provided a connection between in-class and independent activity. It was observed that the patients were happy to share their data between each other, but they were reluctant to see others' data. They wanted to see others' data on a delayed basis. It was also observed that the system enabled patients to share information with clinicians that they were hesitant to share during in-person classes. The timing, the type of application, and the type of data that was shared mattered. It was also observed that subjective data can help to make objective data more meaningful. A structured approach to collecting subjective data helped to make data actionable. That is, by providing information that the clinicians could quickly understand and act on. For example, through conversations with patients and tailoring the educational talks during the cardiac rehabilitation program. Both activity data, that is objective data, and subjective data further bridge the gap between clinical and independent use by helping clinicians to prepare for the classes, gain an insight into patients' mindset, and support in in-class conversations. So, on the basis of our observations and findings, we present the following key themes and design recommendations for patient-generated data systems to support rehabilitation and the transition to self-care. Such systems should support both task-oriented and exploratory use of patient-generated data and the associated self-tracking systems. We should make patient-generated data meaningful and actionable by collecting both subjective experience data and objective tracking data. Structured experience data combined with filtering and summarization can help make patient-generated data more actionable for clinicians. An open approach to subjective data collection gives patients an additional channel to communicate issues that they might be reluctant to discuss in person with clinicians. And to design for peer sharing by carefully considering the level of detail and timing when designing peer sharing features. Sharing detailed information may not be beneficial and should be approached with caution. Delayed sharing, use of narrative format, and a focus on lived experience may be beneficial. To support the transition from clinical care to self-care, use self-tracking and patient-generated data to provide a connection between clinical and non-clinical setting. This can help to bridge the gap between supervised and self-managed care. Furthermore, self-tracking technology should be introduced at an early point in the rehabilitation process. I would like to thank you for taking the time to listen to our presentation and for reading our paper. I would also like to thank the clinicians and patients who participated in our study. If you would like further information, please do get in touch. Thank you.